body cells, muscles, liver, and stimulate glucose uptake. Then glucose level drops, and that is the stimulus for glucagon, right? And glucagon goes and stimulates the fat cells to release glucose, and blood glucose is restored. This is, we talked about this so many times. Now, what we didn't talk about is, everybody talks about insulin. You know, the truth is that insulin synthesis is not a single stage process. As a matter of fact, what the beta cells release is actually this chemical here, peptide, called preproinsulin. It's very long. It is really biologically inactive. That is what the beta cells produce. Preproinsulin is converted to proinsulin, okay, by this enzymes called signal peptidases. Now, proinsulin is also biologically inactive. What we call mature insulin is actually formed by another proteolysis of proinsulin. So proinsulin serves as a stable intermediate hormone, and proinsulin accounts for 20% of circulating insulin. All right, everything I just said is what I wrote here. Now, so when beta cells produce insulin, 20% of your total insulin is what type of insulin? Proinsulin. Good. Very important number to remember, for reasons that will become obvious very clear. This is the third time you're seeing this slide, right? About the counter-regulatory hormones. Remember this slide? Okay. So you remember how insulin and glucagon from the pancreas, they have effect on the liver. Insulin causes glucose uptake by the liver, glucagon causes glucose release by the liver. And when your blood sugar drops, the pancreas responds, the brain also responds. The brain responds two ways. There is a neural response by increasing the sympathetic adrenal outflow, and there is a hormonal response through the pituitary. And the pituitary response brings about increase in growth hormone, increase in ACTH, and that ultimately leads to increase in cortisol. The purpose of this is to bring the blood glucose back up. That's why we call them counter-regulatory hormones, right? Okay. And then you remember epinephrine and norepinephrine and acetylcholine. Where is this released? The post to the sweat gland. Good, you remember that. Okay. And then all of this restores glucose. What I want you to remember here is that when your blood glucose drops, your growth hormone level goes up and your cortisol level goes up. That again becomes important. So two important things I've told you this morning that you must remember. 20% of circulating insulin is proinsulin. And when blood glucose drops, cortisol and growth hormone levels go up. Okay? Provided the pituitary is fine. All right. So let's talk about hypoglycemia. What is hypoglycemia? Blood glucose less than 70. That is biochemical hypoglycemia. But what is clinical hypoglycemia? There's a difference between a number and a clinical entity. There are two types of hypoglycemia. There is a reactive hypoglycemia that is also known as feeding hypoglycemia. And there is a spontaneous hypoglycemia that is also called fasting hypoglycemia. Feeding hypoglycemia occurs within 4 hours of meal consumption. So if your blood sugar drops within 4 hours of eating, you have what is called feeding hypoglycemia. How does that happen? You see, under normal circumstances, this is how insulin and blood glucose match up in the blood. So when you begin to eat, the blood glucose begins to rise. Immediately, the beta cells begin to release insulin. And the blood glucose level and insulin levels rise together, right? And as the blood glucose level falls, so this is what happens in a normal person. If you now get gastric bypass for weight loss, see what happens. When you get gastric bypass for weight loss, part of your intestine is taken out, right? So you drink, so let's say under normal circumstances, this is the normal length of the intestine, right? You expose food, and you have this much surface area to absorb the glucose, right? So you will expect some kind of a rise like that, right? And insulin will follow like that. After gastric bypass, you're taking out some of your intestine. So now you have this. You've lost this, right? There is less surface area for glucose absorption, right? So the peak of glucose will be very high, right? And the beta cells will be like, wow, there is a ton of glucose coming our way. They match it immediately. But now because the power is short, that glucose level drops acutely. And the insulin level is now trying to catch up. You got that? So that mismatch between normal insulin secretion that outlasts the brief and brisk glucose absorption of short bowel syndrome is what the pathophysiologic basis is for feeding hypoglycemia. So you see it in people that have had surgery for weight loss. Okay, so they have to eat like a little bit at a time, every time.
Can someone who hasn't had surgery have reactive hypoglycemia?
It's rare. Unless they have
What if they're sensitive?
bowel disease, like say Crohn's disease that has, and most of their bowel is scarred, right? Okay?
So it has to, you have to have a structural
Yes, you have to have a structural abnormality that interferes with the ability of your intestine to absorb glucose in such a way that your glucose absorption is brief and brisk. Okay? So that fools the beta cells, and they respond with all their might when they see high blood glucose, but before they knew it, it's like the glucose supply drops, and they're already in the circulation, so they push the blood glucose down. So that is all about feeding hypoglycemia. Now, fasting hypoglycemia occurs after a missed meal, and if most people eat 3 square meals, so that means after 8 hours, right? Or more, right? Or a moderate intense physical exertion. That is not normal. Normal people don't become hypoglycemic because they exercise, even if you don't eat. You just don't. It just doesn't happen. If that happens, it is usually a sign that somebody is at risk for diabetes. Okay? That is just the information. So let's now talk about feeding hypoglycemia. What are the causes of it? I want you to, in your mind all the time, talk about hypoglycemia in terms of either lack of glucose or insulin excess. And that really is what causes it all the time. Lack of glucose or insulin excess. How do you end up with lack of glucose? Well, it could be reduced supply or increased demand. Reduced supply, well, starvation, you're not eating. Liver failure, because the liver is what responds to hypoglycemia in a resting person. Alcohol binge. Beta beta blockers, and salicylic overdose. All of these will interfere with glucose supply. Increased demand, tumors, sarcomas, and hepatomas. Sarcomas are smooth muscle cancers. There is a lot of space, especially in the retroperitoneal space. So these cells can actually grow so big that the malignant uptake of glucose can precipitate hypoglycemia in somebody with extensive sarcoma. Okay? And then you have biguanide overdose. These are medications that we use to treat diabetes. And then you have septicemia. Okay? Bugs. So these are the causes of lack of glucose. How about insulin excess? Well, insulin excess, on the other hand, can be absolute or relative. In absolute insulin excess, you have insulin overdose. So you overdose with insulin, you go to hypoglycemia. Then you have insulin secreting tumors that are called insulinomas, right? Then you have oral hypoglycemic agents like sulfonylureas that work by stimulating insulin release, right? Then you have pentamidine. This was the medication we used to give for, what was pentamidine used for? Somebody look it up. Or something, I've forgotten what it's used for. But what it does is toxic to the beta cells. So it destroys the beta cells, and because it destroys the beta cells, the insulin they contain gets released. Okay? So what was pentamidine used for? Oh, trypanosomiasis?
Yes.
Okay, you see, it's one of those antiemetic here. Okay. Okay, trypanosomes. Okay. So, that is how it works. It doesn't cause hypoglycemia by itself, but it's toxic to the beta cells. And when it kills the beta cells, the insulin they contain gets released. And that is how it causes hypoglycemia. And of course, renal failure will give you insulin excess. You know why? Because insulin is cleared by the kidneys. That is the reason you notice that when diabetics are developing renal failure, all of a sudden their glucose is better controlled because their insulin is lasting longer in circulation as a result of reduced renal clearance. Got that? Now, what is relative insulin excess? Relative insulin excess is seen when there is counter-regulatory deficiency, right? So if growth hormone is supposed to work against insulin, when growth hormone is not there, insulin will do overwork, right? If cortisol is supposed to work against insulin, when cortisol is not there, then insulin will be in excess. It will overwork, right? So all of those conditions, growth hormone deficiency, glucagon deficiency, and renal deficiency, is what we call altogether counter-regulatory deficiencies. Okay? How does it present? Hypoglycemia has two sets of symptoms: early symptoms and late symptoms. The early symptoms are usually warning signs. Okay? So they are driven mostly by sympathetic nervous system. When patients with diabetic patients, a patient with diabetes, develop autonomic neuropathy, they lose these warning signs because of sympathetic nervous system neuropathy. That is the reason that it is possible for you to find a diabetic in coma from insulin overdose. A normal person will get a warning sign. And that warning sign is usually driven or mediated by the sympathetic nervous system. And it consists of headache, hunger, sweatiness, shakiness, irritability, weakness, and tachycardia. All of this will warn you so you can go and do something to avert your passing out. If for any reason you don't have the intact nervous system to get this warning, you go straight into the late manifestations of hypoglycemia. If you're sleeping, you'll get a nightmare. So anytime a diabetic patient tells you that somebody was chasing them in their dream with a club, that that is usually the kind of dreams you have when your blood sugar drops in your sleep. You get nightmares. Okay? Nervousness, delirium, drowsiness, ataxia, coma. And if you look in the books, you will see convulsion. It is not possible for you to have convulsion when your blood glucose is low. Think about it. The body is wired to self-preserve at all times. Is it self-preserving for the body to cease when glucose is low? It's not possible. I've never seen it. But it's in the books. But let me ask you, why is it, how did you make it into the book then?
Some epileptic seized.
Yeah, somebody seized and somebody checked the sugar after the seizure. Right? So the seizure caused the hypoglycemia. It's not that the hypoglycemia caused the seizure. You got it? Yeah. That is one of the problems with association studies. It's like the chicken and the egg, which one came first? Right? So you will see it in the books. It is written all over the place. Seizures as a cause of hypoglycemia. It is not true. Okay? The body will not destroy itself. The energy for conversion is not available in hypoglycemic patient. The body will go bankrupt if the body does that. Now, I told you there is a difference between a low blood sugar reading and hypoglycemia. In order for you to say your patient is hypoglycemic, you have to fulfill 3 criteria. And those 3 criteria were first introduced to medicine by Alan Whipple. So they are known as Whipple triad. So Whipple says, in order for you to say your patient has hypoglycemia, your patient must have symptoms of hypoglycemia, shaky, sweaty, and when you measure the blood glucose, it must be low, right? And then when the patient is given glucose, the symptoms stopped. 3 of them must be fulfilled for you to say your patient has hypoglycemia. If 3 of them are not fulfilled, you cannot say your patient has clinical hypoglycemia. Okay? I'll tell you why this is important. There are situations where you have a patient that will show evidence of low blood glucose, clinical signs, shaky, sweaty. But when you test the sugar, it will be normal. You will not call that patient hypoglycemic. You will diagnose that patient with pseudo hypoglycemia. Pseudo, false. Under what circumstances would you see that? 3 basic conditions will give you pseudo hypoglycemia. One is slow capillary refill or slow capillary blood flow. You find it in Eisenmenger syndrome. You all know what that is now. Reynolds phenomenon and in circulatory shock. So basically what this is that the patient is symptomatic, not because there isn't glucose in the blood, but the blood is not flowing fast enough to deliver the glucose to the brain and the body. Okay, so you find it in these slow capillary blood flow states. You also find it in hyperviscosity syndrome, when the blood is too thick. Again, not flowing as fast as it should, okay, to deliver the glucose that it has to the body. And you find out in Waldenström macroglobulinemia, you know what that is, right?
Yeah.
Multiple myeloma, monoclonal gammopathies, and sometimes in severe hyperlipidemia. And then the third cause of pseudo hypoglycemia is glucostasis. You know what that is?
Yeah.
Is when your circulation slows down because of extreme numbers of white cells in circulation. Okay, so all of this will give you pseudo hypoglycemia. Now you see why Whipple's triad is important. Yeah, here you have a symptomatic patient, and the blood glucose is normal. If you're not aware of pseudo hypoglycemia, you call the patient hypoglycemic. And then there is the second one, artificial hypoglycemia, fake hypoglycemia. Here you have an asymptomatic patient with a low blood glucose level. Many times in clinics, your medical assistant will come to you, they will run to your office. We have a patient in the waiting room with a blood glucose of 45. I'm like, did he talk to you? He said yes. Okay, I said, put the patient in the room. We're like, oh, why are you not alarmed? Well, because if the guy is talking to you with a blood glucose of 45, his blood glucose cannot really be 45. At 45, you'll be out, right? So how does that happen? Or sometimes you get a call, usually on a Sunday morning. And it usually comes when blood is ordered late in the evening or in the afternoon on Fridays. Because you know, this LabCorp and the Quest laboratories, they pick up at specific times during the day. So on Monday, they may come every day at 4 o'clock. So if you order blood draw on a patient at say 4:30, when the pickup is already, the guy is already gone, the blood will be left in the refrigerator until Monday. Well, the blood is in the refrigerator with red cells and white cells, and they are not going to starve. They will keep chewing on the glucose that is in the blood. So by the time the sample gets to the lab on Monday, the glucose is chewed out by the red cells and the white cells. So it will be like 28, 35. And the lab guy will freak out like, hey, your patient, what is it, emergency lab. And they will call and they'll say, oh, you say, okay. You know you saw the patient, the patient went home. So if I will take care of it when the patient comes next. So that is how that happens. Delayed sample analysis. And there are times you have rapid glucose utilization by cells within the sample, right? So you draw the blood for somebody with, say, leukemia, or somebody with, somebody with polycythemia, right? Or somebody with trypanosomiasis, right? These are parasites. They are inside the patient. For as long as they're inside the patient, they are chewing glucose, but once they drop the blood glucose, the body will replace it. Now you draw the patient sample with all those parasites in it, and then you sit it down for 6 hours for the pickup. They chew it up before the pickup guy comes. Not because it was left overnight, but there are just so many of them, so many cells utilizing glucose that even the normal waiting time is enough for them to drop the blood glucose. You got that? Yeah.
So does this, you also get a low reading when you do an actual stick?
No, you will not get a low reading because when you do the finger prick, it's immediate. Right? So you will not get a low reading in this case over here. It is when you draw the sample line, you sit it down. Right? And then if you do somebody's finger stick, when they are taking high doses of vitamin D and Tylenol, you might end up with a low reading as well. Because vitamin C and Tylenol, they actually interfere with the reaction, the chemical reaction on which that glucometer thing is based. Okay, so these are two important differential diagnoses of hypoglycemia. False hypoglycemia, that is called pseudo hypoglycemia, and fake hypoglycemia, which is called artificial hypoglycemia. I give you the references just in case somebody will ask you, what is that? You can say it's known. You can give that reference, okay? How do you manage it? Well, it depends. If your patient is alert and oriented, you give them glucose tablets, and it exceeds 25 to 100 milligrams. If they are altered, you give them intravenous push of D50, and then you run D10 to maintain it. If your patient does not have IV access, you give IM or subcutaneous glucagon, 0.5 to 1 milligram, and you admit your patient. The only time you admit and fast the patient to 24-hour hold and fast is when the cause for the hypoglycemia is not apparent. If you don't know why the patient developed hypoglycemia, you admit them and you hold them for 24 hours. Okay? Are you all with me? Good. Once you hold them, what? Spider? I thought it was a snake.
No, that's what you run out of here.
It's gone. Don't worry about it. It's dead.
Should I call 911?
City kids, man.
It's in Brad's backpack.
All right. So, whenever you diagnose somebody with hypoglycemia and the cause is not obvious, you will admit them and you will hold them at least for 24 hours. Why 24 hours? Because you want the blood sugar to drop again. You want the blood sugar to drop again so you can draw the lab. See, you want to draw the lab for glucose, insulin, pro-insulin, growth hormone, and cortisol. You must remember all of this. Okay? There are other reasons why you want to hold your patient. Supposing you know that somebody overdosed on Lantus. You know, Lantus can last up to 24 hours. So you know that they will go back into hypoglycemia. So you hold them to make sure that the Lantus washes out of their system. Okay? And then, if your patient with hypoglycemia, say for instance, they brought a patient to you in the emergency room, and your patient is out. Then you catch the patient, you give glucose, and your patient does not wake up after the blood glucose goes up. The patient remains comatose. That means that hypoglycemia did not cause the coma. The patient became hypoglycemic because they went into coma. You got it? Because under those circumstances, your patient should wake up when you push glucose, if hypoglycemia was the reason for the coma. But if your patient in coma does not wake up after you push glucose, that means the coma caused the hypoglycemia, not the other way around. Okay? Then you are dealing with a neurologic deficit, a neurologic problem. Okay? Now, why do you need to do all these tests? Because of this. Right? So, this table is the reason you need to do all that test. So, under normal circumstances, this is where you want to stop writing, look up, and make sure you understand this. Under normal circumstances, when your blood glucose drops, your insulin level should drop. Right? And C-peptide, remember C-peptide? C-peptide is that peptide that was cleaved off of pro-insulin to form mature insulin. Okay? So, C-peptide level will be low anytime insulin level is low, provided the insulin is coming from the pancreas. Okay? Remember what I said? When glucose level is low, insulin level will be low, provided that insulin is coming from the beta cells. Because beta cells will shut off insulin secretion when blood glucose goes down. C-peptide will be low, provided the insulin is coming from the beta cells. Because remember, it is the beta cells that secrete pre-proinsulin that gets converted to proinsulin and ultimately gets converted to mature insulin. So if the insulin was off the beta cells, C-peptide will be low. And proinsulin will be less than 0.2 nanogram per mil, which is less than 20%. I told you that when beta cells produce insulin, 20% of the insulin they produce is proinsulin. So when the insulin level is low, the proportion will still be less than 20%. Okay? In a normal person, when blood glucose drops, you expect growth hormone and cortisol to respond to that. Okay? So you expect growth hormone and cortisol to be elevated. That is what normal is. Right? Good. Now let's talk about sulfonylurea overdose. Sulfonylurea are medications that stimulate the beta cells to release insulin. Okay? So somebody overdosed on sulfonylurea. They will drop their glucose, and strangely enough, their insulin level will be high, even though their blood glucose is low. Because this is not coming from a normal beta cell. It's coming from a beta cell that is under the influence of sulfonylurea. So in spite of low glucose, they will have high insulin. And because that insulin is coming from beta cells under the influence of sulfonylureas, the C-peptide also will be elevated, right? And the proinsulin will be still 20% or less. Okay? And because glucose is low, the growth hormone and the cortisol level will be elevated. You got that? Okay. Now let's think about somebody with an insulinoma. So here is a beta cell that is gone rogue. It's a tumor, it's a malignant tumor of the beta cell. So it's an insulinoma. An insulinoma will drive your glucose low in the presence of low blood glucose. Insulin levels will still be high because it's coming from an insulinoma that does not respect blood glucose, right? And because insulin level is high, C-peptide will be high. But now look, proinsulin is more than 20%. Whenever insulin is of a malignant origin, proinsulin levels are no longer 20%. They're usually, so malignant sources of insulin produce more proinsulin than normal beta cells, right? So increased proinsulin is one of your markers for pancreatic insulinoma, okay? And then, again, as usual, your growth hormone and your cortisol will respond to low blood glucose by increasing their levels. Now, let's talk about insulin overdose. So it says a patient overdosed on insulin. So what will happen in that case? Well, in insulin overdose, glucose level will be low. Insulin levels will be high because the patient injected it. But C-peptide will be low because that insulin did not come from within. It came from outside of the patient. The patient injected it. The beta cells didn't secrete it. So C-peptide will be low, right? Proinsulin will be low for the same reason. The insulin did not come from beta cells. It came from outside. The patient injected it. You got it? Again, as usual, your growth hormone and your cortisol levels will be elevated in response to that low blood glucose. The presentation of insulin overdose and insulin antibodies is exactly the same. Okay? So clinically from this test, you cannot differentiate between insulin overdose versus insulin antibodies, because insulin antibodies, they stimulate the body just like insulin does. And even the measurement of insulin cannot differentiate between insulin antibodies and insulin. So clinically it's very difficult. Now, let's talk about a patient with growth hormone deficiency. In a patient with growth hormone deficiency, glucose will be low because insulin is overworking. Insulin level will be low. C-peptide will be low because glucose is low. Proinsulin will be low. Growth hormone will be low, but cortisol level will be high. You got that? So you have low blood glucose, everything else is fine. Insulin is responding appropriately because blood glucose is low, so insulin drops, right? C-peptide drops because blood glucose is low. Proinsulin drops because blood glucose is low. Cortisol increases as a response, but growth hormone cannot increase because the problem is growth hormone deficiency. You got it? And that is exactly the same pattern for adrenal insufficiency that will give you cortisol insufficiency. It will give you, everything will be normal, glucose will be low, insulin will be low because glucose is low, C-peptide will be low because insulin is low, proinsulin will be low because insulin is low, growth hormone will be increased because pituitary is intact, but cortisol will be less because of cortisol deficiency. So you see, that is how you kind of evaluate hypoglycemia to figure out whether the patient overdosed on insulin, sulfonylurea, they have growth hormone deficiency, or whatever. That's how you do it. So now, let's see how much of this you really know. Okay? So, Emmy, this is your welcome gift. So, what do you think is happening to that first patient? Glucose is low, insulin is high, C-peptide is low, proinsulin is less than 20%, cortisol is high, growth hormone is high. What do you think is happening here? What overdose? Thank you. Anybody think different? Because the fact that the sugar is low means the patient is truly hypoglycemic. The fact that the insulin is high means insulin is making the patient hypoglycemic. The fact that C-peptide is low means that insulin did not come from within the patient, right? The fact that proinsulin is less than 20% means, again, that the insulin did not come from within the patient. Cortisol is high, growth hormone is high, means pituitary and adrenals are responding appropriately. So this is an exogenous source of insulin. Insulin overdose, just accurately said. You got that? Or insulin antibodies. Yeah. But insulin antibodies are so rare clinically. So insulin overdose would be what you would say on the normal circumstances. Right. Okay, so Tolu, what do you think about this? So glucose is low, insulin is low, C-peptide is low, proinsulin is less than 20%, growth hormone is high, but cortisol is low. Exactly, cortisol deficiency. You got that? Good. So, Stanley. Eh? What brand? Okay. Stanley. That third case. Glucose is low. Hello.
Yeah, I'm looking at it.
Glucose is low.
Yeah.
Insulin is high. That means insulin is driving that glucose.
Yeah.
C-peptide is high. So that means that insulin is coming from within. Right? Proinsulin is more than 20%. So it's coming from within, from an abnormal source.
So you got the insulinoma?
Thank you.
Hey.
That's it. See, that is how I want you to interpret those numbers. Okay? All right, loss. Fourth case. Glucose is low, right? Insulin is high. That means insulin is driving this glucose, right? C-peptide is high. That means that insulin is from inside the body. Proinsulin is less than 20%. That means that insulin is from the usual source of insulin inside the body, right? And this growth hormone is high, cortisol is high. What do you think that is?
Overdose on sulfonylurea.
Thank you. Something is stimulating the beta cells to produce insulin abnormally. You got that? Excellent. Steph, the fifth case. Glucose is low. Insulin is high. So that means insulin is causing that problem. But C-peptide is low. That means that insulin is not coming from the normal source it's not coming from the body. Right? It's coming from outside. Proinsulin is less than 20%. What you will expect? Glucose is high and cortisol is high. What do you think this is? Insulin antibodies or insulin overdose, right? Okay. All right. Marian, how about the sixth case? Glucose is low, insulin is low, C-peptide is low, proinsulin is low, growth hormone is low, cortisol is high. There's a growth hormone deficiency. Okay, so you got this. Okay, Vinny, what is this one?
Low insulin, low C-peptide, low proinsulin, normal.
Thank you. All right. So you see how you figure this out? What's that?
Because we were just laughing because we were like, oh, the answers for the next slide.
And
we were really trying.
Hey, you know, sometimes
We didn't realize until after we'd already gone through all of them. Yeah.
I'm glad you did that.
Oh, Wendy.
Hear that?
What happened?
Oh, there's water here.
Sorry.
That's darn it.
Oh my God, that scared me. Okay. All right, so let's take a look at this together. You are called to evaluate a 35-year-old obese female with recurrent blood glucose levels between 40 and 60 milligrams per deciliter. Patient is on admission for orbital fracture after she ran into the open door of a public bus. Admission blood tests were normal except for serum calcium of 13.3. What is the most likely cause of this hypoglycemia? Bradley.
I'm going to say long tail bus has over the factor.
Let's think through the case. She's 35 years old. She's obese. This is happening not once, not twice. It's been happening recurrently. She is on admission because she was trying to get in the bus, but she ran into the side of the bus. The door of the bus was open. Right? if somebody is running into objects that they should have seen on the side, what do you think is happening to them?
Pituitary.
Thank you. They're losing peripheral visual field, right? Right? And because she's losing peripheral visual field, she's running to. Now, why is the serum calcium high?
It's probably affecting the peritoneum.
Yeah. Huh?
Isn't it because she has a fracture?
Does fracture cause hypercalcemia?
So the pituitary too.
But you're on the right track. Keep thinking.
Parathyroid, like I mean.
Yeah, there is a parathyroid. So if somebody has a pituitary tumor and a parathyroid tumor, what is that? Multiple endocrine neoplasia. Yes. So it's a multiple endocrine neoplasia. So that hypoglycemia is most likely coming from insulinoma. You got that?
Yeah.
Good. You should be thankful I didn't send your past questions. Are we good?
How do we rule out alcohol? If someone's riding to a bus, that's because
Yeah, they could be drunk.
She's on admission. She's been on admission. Is she getting drunk on admission?
this shit is on it. I mean, I would assume, I read that she came into the ER, so.
She has recurrent hypoglycemia. She's on admission for orbital fracture. On admission, she ran into the open door. She didn't trip. Trying to get on the bus. Okay, alcoholics bump into people because they stagger, not because they don't see them. Right? As a matter of fact, trying to avoid you is what brings them to you sometimes. Right? Right? So it can't be starvation because she's in the hospital. She's obese. Physical exertion, she's not been running. She's on admission. Alcohol binge, she wasn't drunk. They said admission blood tests were all normal. And really, one thing I should also tell you is that the hypoglycemia of alcohol intoxication usually happens when the patient is acutely intoxicated.
What did you say?
Yeah, they have to be acutely intoxicated. All right, so that's that. You guys, we don't need a break right now. So we're going to go to hyperglycemia. Any question on? So this is all about hypoglycemia. This is all there is to it. There is nothing else on planet Earth in 2019. That is all we know. Where we get the Martians coming down here, the anatomy and pathophysiology might differ. But for today, among humans on this planet, there is nothing more to hypoglycemia. Everything else is extra. Any questions?
Wait, so she bumped into the open door because of the hypoglycemia and her peripheral vision.
Because she has bitemporal hemianopsia. That's why she ran into the open door.
And that's from the hypoglycemia?
That is from the pituitary tumor, the compression of the optic chiasm. That gives you the bitemporal hemianopsia. That's why she didn't see the door open. Okay? You know that patients with bitemporal hemianopsia, they present like patients with tunnel vision, right? So they lose peripheral vision. They see like they're looking through a tunnel. So they are the ones that will bump into you, and you think they are looking for trouble, but they didn't even see you. Okay? That happens in two conditions. Bitemporal hemianopsia from pituitary tumors and glaucoma, chronic glaucoma. Okay? Got it? Right, yes.
Is there multiple endocrine type 1?
Huh?
Is there multiple endocrine neoplasia type 1?
No. Type 2A. The one with pituitary, parathyroid, and pancreatic tumor.
That's type 1.
That's type 1?
Yeah.
Oh, typically say the one with leukocytoma. It's type 1. Yes. Thank you. All right. Any more questions, concern? Clarification, we're good? Let's move on.
Yes, sir.
Okay, so let's do this now. hyperglycemia, so the flip side of hypoglycemia. So hyperglycemia is really fasting blood glucose more than 800 or random blood glucose more than 200. So if you go to health screen and you check somebody's glucose and their glucose is more than 100 in the morning before they ate, that is hyperglycemia. I didn't say they're diabetic, I said they have hyperglycemia. If at any time during the day, blood sugar is more than 200 milligrams per deciliter, that person has hyperglycemia. Now, there are three basic causes of hyperglycemia: diabetes, prediabetes. When the fasting blood glucose is between 125 and 100, that is prediabetes. When it's more than 126, that is the official definition of diabetes. When random blood glucose is between 140 and 199, that is prediabetes. When it is more than 200, that is diabetes. Okay? What are the causes of hyperglycemia? Well, remember, when we talk about hypoglycemia, we talk about lack of glucose, insulin excess, right? For hyperglycemia, we talk about glucose excess and lack of insulin, right? Glucose excess, increase supply or reduce uptake. How do you get increased supply? TPN. You know? Did I tell you that story about the surgeons that put the patient on deliver 2? No? When I was an intern, right? The surgeons brought a consult to internal medicine consult. And I was on consult service. I think I was in second year or third year. And I went, and the consult was, they wanted us to help control atrial fibrillation that the patient developed about maybe 10 days after they had their exploratory laboratory for some bowel condition the patient had. So you know what they did? After their surgery, instead of dropping a nutrition consult for a nutritionist to come and help them with how they're going to feed their patient while the patient heals, they took it upon themselves to put an NG tube and start putting NG feed on the patient. And NG feed are different types. There is glucagon for diabetics. There is deliver number 1 for regular people. There is deliver number 2 for those that are healing. There is high protein ensure for patients that are septic. They didn't know the difference. They just picked deliver 2, right? And started pumping deliver 2. Deliver 2 has 2 times the amount of sugar. Of course, the patient blood glucose started going up. And again, instead of dropping endocrine consult, I just gave sliding scale insulin. So they started giving sliding scale insulin. Okay, tell me something. What happens when you put glucose and insulin into a patient? What will happen to potassium? Yeah. Because insulin moves glucose into the cell with potassium. So you will cause a massive, rapid shift of potassium from the blood straight into the cell. So the patient went into severe hypokalemia and straight to the AFib. Like, I was like, you freaking idiots. What are you doing? But I had so much fun because you know how surgeons are, right? Okay, so TPN, NG2 feeding can cause that problem. Reduced uptake, mostly medication related. Oral contraceptive pills, we've gotten better now. They're not a common cause anymore. You know, but I needed to spare spindle, so I put extra, I retained them there. Okay, steroids, phenytoin, INH, niacin, diuretics, Remember I told you in hypertension class that diuretics, especially the thiazide diuretics, they cause elevated blood glucose. They don't cause diabetes. They cause elevated blood glucose. Because what happens with thiazide diuretics is that the blood glucose go up and flattens out. It never continues to go up. They develop this hyperglycemia and it stays up. It never progress to diabetes. Okay? Now, let's talk about lack of insulin. How do you get lack of insulin? Well, pancreatic disorders, chronic pancreatitis, commonest cause, alcoholic. And then there is autoimmune pancreatitis, where the body produces beta cell antibodies that destroy the beta cells. Okay? And then you have adenocarcinomas, you have somatostatinomas, delta cell tumors, and then you have hemochromatosis that damages pancreas as well. Adenocarcinoma, somatostatinoma, hemochromatosis, you need to be able to diagnose. I will give you clues. Relative counter-regulatory excesses, growth hormone, glucagon, cortisol, catecholamine. That is why sometimes patients with pheochromocytomas can actually exhibit increased blood glucose. Okay? Questions? When somebody's blood glucose goes up, depending on what is causing the blood sugar to go up, the patient can be simple manifestation or some serious complicated manifestations. So let's talk about patient with relative insulin deficiency. So that would be somebody with acromegaly, somebody with Cushing's, or any other pheochromocytomas. They would develop hyperglycemia, they will develop diabetes, but they will never develop ketogenesis. Okay? If they don't form ketone bodies with relative insulin deficiencies, absent or very minimal ketogenesis. Whenever somebody develops absolute insulin deficiency, that means the cells cannot utilize glucose because they can't take it. It can't come in. Insulin is needed for the body cells to take up glucose. So when the body cells cannot take up glucose, they now start breaking down fatty acids within. So that leads to lipolysis. As they break down fatty acids, the free fatty acid flow to the liver increases. And there is nothing the liver can do with that free fatty acid flow but to convert them to ketone bodies. And those ketone bodies, or ketone acids, they are acids. They have to be neutralized by bicon. So this patient's alkaline reserve dips and the patient develops ketoacidosis. Okay? So whenever there is an absolute insulin deficiency, you will get ketoacidosis. And because of these free fatty acids, you also get hyperlipidemia. Now, as a result of increase in counter-regulatory hormone, you also get decreased glucose utilization and increased glycogenolysis. Okay? What the counter-regulatory hormones do when the cells cannot take up glucose is to put a stop on protein synthesis and to again promote protein breakdown. Because remember, when the body cells cannot take up glucose, they have to look for alternative sources of energy, and they rely on fat and protein. So the ability of the body to break down protein and stop protein synthesis is under the influence of the counter-regulatory hormone. And the reason they break down protein is because the protein breakdown products are actually gluconeogenetic substrates that the body will now use to form new glucose. And that is how you get your hyperglycemia. And of course, serum glucose will drop. And when serum glucose exceeds 200, the glucose filtration proceeds at such a high rate and it exceeds the tubular maximum. Do you know what tubular maximum is? The tubular maximum for glucose is the point, the serum level of glucose at which the kidneys cannot reclaim everything that is filtered. The tubular maximum varies for substance, from one substance to another. For glucose, it's about 200. So when serum glucose is above 200, the kidneys are not able to reclaim everything, so it begins to leak into urine. Okay? So you now get hyperglycemia, then you get glycosuria, and of course, because it's a solid diuresis, it's also an osmotic diuresis. It drags water with it and put the patient into dehydration. So you see why hyperglycemia in the presence of absolute insulin deficiency and increased counter-regulatory hormones, primarily growth hormone and cortisol, will lead to ketoacidosis in addition to hyperglycemia. Remember that. Remember that. This is so important in understanding what we're going to be talking about next. Okay? The hepatic oxidation, yada yada yada, ketone bodies, blah blah blah. Okay. How does hyperglycemia present? Many times it is asymptomatic. Patient does not have any symptom, but when they measure the sugar is high. Whenever that is the case, you should think about increased glucose supply, like in those surgeons that gave the patient liver number 2, or medication interference with the peripheral glucose uptake, or new onset diabetes. Many times diabetes is asymptomatic. When it is symptomatic, patients present with polyuria, polydipsia, volume depletion, and if it's been on long enough, weight loss. You know now why they develop polyuria, why they develop polydipsia, and why they develop volume depletion. Now, if there is an absolute insulin deficiency, they will develop ketoacidosis. Right? You know that has to do with the fatty acid breaker, right? Good. They develop ketoacidosis. Now, with ketoacidosis, they will have nausea and vomiting, they will have abdominal pain, they will have deep, rapid breathing, and there will be a sweet, fruity breath odor. So when you go near the patient's nose, the breath has a very sweet smelling, like fruit basket. Okay? Mm-hmm. And that is because of one of the ketone bodies called acetone. Have you smelled acetone before?
Yeah.
Good. What does it smell like?
Sweet.
It's not like nail polish, right?
It's the same thing.
All right. Now, if nobody does anything about hyperglycemia and it continues, the patient will go into coma. There are two types of hyperglycemic coma. There is a diabetic ketoacidotic coma. That is the coma that is as a result of ketoacidosis and hyperglycemia together. That type of ketoacidosis is seen only in patients with type 1 diabetes mellitus. Now, the second type of coma you see in diabetes is the hyperosmolar non-ketotic. You see, the hyperosmolar non-ketotic is seen in type 2 diabetes mellitus. Let's go through that. Hyperosmolar. That means it is just severe elevation in blood glucose that is increasing the serum osmolality and dehydrating the cells by pulling water from inside the cells to outside of the cells. And that is what is primarily responsible for the coma. They are not ketotic. because they're not ketotic, there is no acidosis. Okay? So remember, there are two types of diabetes coma. There is diabetic ketoacidotic coma, and there is the hyposmolar non-ketotic coma. You see in type 1 and type 2 respectively. And you remember that type 1 diabetes is usually due to absolute insulin deficiency. And type 2 diabetes is really due to relative insulin deficiency. Okay? And diabetes, of course, is the commonest cause of chronic hyperglycemia. So how do you diagnose diabetes? Again, I've given you this fasting blood glucose and random blood glucose before, but now we are also allowed to diagnose diabetes with hemoglobin A1C. Normal hemoglobin A1C is about 5. When it is between 5.7 to 6.4, you call that prediabetes. When it is 6.5 or more, 6.5 or more, you call that diabetes. Remember, 6.5 or more. So 6.5 is diabetes. You got that? Now, hemoglobin A1C reflects chronicity of hyperglycemia. So generally speaking, when you have increased hemoglobin A1C, that means your hyperglycemia has been around for at least 3 months. Because remember, the average red cell lives for about 120 days, right? It's about 4 months, right? And they carry hemoglobin. And hemoglobin A1C is this unholy alliance between glucose and hemoglobin that is formed only when there is excessive amount of glucose in blood, right? So you have A1C to help you determine for how long the patient has had hyperglycemia. Okay? So if somebody comes to tell you, you see a patient and in the clinic their blood sugar is 110 and A1C is 13, is that patient in well control? What if the clinic glucose is 280 but A1C is 6? Is that patient well controlled? Yes! Maybe they just ate or drank a soda, right? So A1C is more reliable when you're trying to judge blood glucose control. If you have access to it, it carries more weight. So somebody can come to the clinic with normal blood glucose. But if A1C is high, that means, yeah, this normal you're looking at now is the exception. The rule is that their blood glucose is high most of the other times. And if somebody has blood glucose of 300 now, but A1C of 7, that means, no, this 300 you're looking at is just now. For most of the other time, their blood glucose is actually normal. So generally speaking, once we diagnose diabetes, we want to classify it. We want to say, what type of diabetes is this? And there are 2 types of diabetes. There is primary diabetes and there is secondary diabetes. Primary diabetes is divided into 2 main types, type 1 or type 2. There are other diabetes that diabetes was so confusing. One time we had type 1.5. Because you see, we grew up believing that type 1 diabetes is due to absolute insulin deficiency and type 2 is due to relative insulin deficiency. And everybody believed, okay, so type 1, if you don't treat them, they always go into ketoacidosis. And type 2, if you don't treat them, they will just maintain high blood glucose. They might go into hyposmolar non-ketotic coma, but most of the time they're okay. That was how we developed it. And we said, okay, fine. Type 1 is seen in young people, children and young adults. Type 2 is seen in overweight adult people. And everybody went home, say that's fine. Then in practice, people started seeing type 2 diabetes that went into ketoacidosis. Now, yeah. They said, no, they converted. And then we started seeing type 1 patients that didn't go into ketoacidosis when they missed their insulin. And then it became very confusing. And it's like, maybe there's a type 1.5. And then the Endocrine Society met and they said, oh, no. Actually, there are other categories. And they came up with all these stupid things like maturity onset diabetes of the young, they call it MODY, and Wolfram syndrome of diabetes, deep mode. This is FY. Okay? What I want you to remember is primary diabetes, two types, type 1, type 2. Type 2 is relative insulin deficiency associated with obesity, insulin resistance. Because remember, do you understand the concept of insulin resistance?
Yeah.
Because you see, what insulin does is to take glucose from circulation inside the cell. And when you're well fed and you're always eating and drinking, like most of you are, that glucose gets converted into fat, right? And the fat cells, they are cells, right? There is only so much room inside the cell. So when insulin comes and begin to talk glucose inside the cell, well, when the cell is full now. Right? Now the cell is filled with fat. There's no more room. But insulin is still there, but there is no more room. So insulin can be there. You can't get any more glucose into that cell. So we describe this state as insulin resistance. It's not that the cell is resisting insulin, it just has no more room for cells. And that is when the insulin now starts to talk glucose where it does not belong. So you begin to form fatty liver. You begin to put fat in your trunk, right? But all of that is called insulin resistance. But really, even though we call it insulin resistance, it's not like insulin, the body is fighting or the cells is fighting. It's just that there is no more room inside the adipocytes. Okay, so insulin is high, usually. So that is called relative insulin deficiency. Now, type 1 is an absolute insulin deficiency clinical condition. There are two types or two subtypes of type 1. There is type 1A and type 1B. And the difference is really immaterial clinically, but you need to know it. Type 1A is the most common one, 95%. It has a very interesting association with the human leukocyte antigen D, beta cells autoimmune destruction, and there is a type 1B that is 5% that we cannot associate with anything. So the sub-classification of type 1 is based on, do we have any understanding as to why it is happening, or do we know nothing about it? We know something about most of it. That is why we know they are linked to human leukocyte antigen. You know that? You don't remember that? Human leukocyte antigen is like the ID banner on the side. Okay. All right. But bottom line is that type 1 is due to autoimmune destruction of the beta cells. Okay? And then, so that's all about the primary diabetes. They have the secondary diabetes. Secondary diabetes, that could be due to increased glucose supply, like those on here on state, or reduced glucose uptake, drug interference, or you can have pancreatic diseases, like we said, chronic pancreatitis, adenocarcinoma of the pancreas, somatostenomas, and hemochromatosis. Or you have counter-regulatory excesses like acromegaly, glucagonoma, Cushing syndrome, pheochromocytoma, or you got pregnant. Another counter-regulatory hormone is placental lactogen. What is that hormone that is secreted by the placenta to increase glucose? What is it called?
Beta ACG.
No, beta ACG is not really from the placenta, right? It's from the ovaries, right? That one from the placenta lactogen something, PL something. You guys are believing you're not okay. All right, there is some pregnancy hormone. Many of the hormones in pregnancy really are counter-regulatory, many of them, including beta ACG. Okay, and there's this other one called placental lactogen something. I don't remember what it is now. All right, but you got the idea, right? All right. Pregnancy Human, that's the one I was talking about. Okay. Yes, HPL. So, this is just a digression. I'm not an obstetrician. I never really dealt in this, not even as an intern. But pregnancy predisposes you to diabetes. And if you have a genetic predisposition to diabetes, you can get away with diabetes until you get pregnant. When you get pregnant, you will develop diabetes. And if you're lucky, once the baby is out, the diabetes goes away. If you're lucky, it stays. All right? In pregnancy, we have a specific protocol for diagnosing diabetes. That specific diabetes is a type of secondary diabetes called gestational diabetes. And that is what I want to tell you about this. It's based on these measures. Obstetricians do it. You should know about something like that is called gestational diabetes, right? And that's what I want to say about that. Now, when somebody is overweight, and they've been overweight for a long time, if they have a genetic predisposition to diabetes, they will develop diabetes. But you know what's interesting? You can actually identify somebody who is overweight that is likely to develop diabetes very soon. They have these things called acanthosis nigricans. It's a thickened, velvety darkening of the skin in the posterior and lateral fold of the neck, armpit, groin, and forehead. It may be genetically inherited, but it's more commonly acquired and associated with metabolic syndrome and endocrine disorders. These are the conditions that you will see that in insulin resistance, hypothyroidism, acromegaly, and Cushing's. So in practice, when you say acanthosis nigricans on somebody who is overweight on a routine visit, that is somebody that is just diabetes, hypothyroidism, or something is knocking on the door. You want to really, really emphasize weight loss. You know, I see this a lot in high school kids, and I worry, because that is not a good thing. The longer you have diabetes, the more likely to do the gain. All right? So, that is about diabetes and physical examination. What else is out there? Now, there are some important clinical manifestations of secondary diabetes that once you're familiar with them, you will never miss a case of secondary diabetes. Adenocarcinoma. How would you know when a secondary diabetes is as a result of an adenocarcinoma? History of heavy smoking and diabetes after the age of 60. So you see diabetic patients. Remember, I did not say diabetes at age 60. No, I said diabetes after age 60. That means you knew that this patient did not have diabetes when they were 55. You knew for sure that they did not have diabetes when they were 58. And then they developed diabetes after age 60. And they have a history of heavy smoking. You must do CT scan of the abdomen to rule out adenocarcinoma of the pancreas. If you don't, adenocarcinomas of the pancreas, they tend to come from the head of the pancreas, where the common bile duct is traveling. And the common bile duct will get obstructed. And when the common bile duct gets obstructed, what is that place in the duodenum where the pancreatic duct and the common bile duct open?
Sphincter of Odin?
Ampulla of Vater, exactly. So many times adenocarcinoma of the pancreas happens in the head of the pancreas. It occludes ampulla of Vater and then causes obstructive jaundice. With obstructive jaundice, the conjugated bilirubin gets filtered, right? So the urine gets darkened, and because bilirubin is not making it into the gut, the stool becomes pale. You got that, right?
So can you repeat that again? That was very fast.
When you have adenocarcinoma of the pancreas, it tends to be located at the head of the pancreas, right? You know the pancreas is like that thing like that, right? Adenocarcinoma happens here. Somewhere in the gut, ampulla of Vater right there. Adenocarcinoma will obstruct the common bile duct. When the common bile duct obstructed, the conjugated bilirubin will not be able to access the duodenum. It can exit. And because it's already conjugated, it is water soluble, right? And because it's water soluble, the kidneys will filter it. And because the kidneys filter it, it makes the urine dark, right? Now, remember the color of your stool is from biliverdin, and biliverdin is formed from bilirubin. Well, if you have something at the head of the pancreas preventing bilirubin from getting into the duodenum and into the bowel, then your stool is not going to have color. So you're going to have pale stool and dark urine. Those are the cardinal symptoms of obstructive jaundice. Okay? Good. So that, when you see that, you worry. Adenocarcinoma. You have to worry. You know why you have to worry? Because pancreatic cancers, they kill a lot of people. You know why? It's not because they're not treatable, but we diagnose them often very late. One of my friends, who's a surgeon, said, we diagnose pancreatic cancer so late that after the surgery, you don't know what to throw away, the patients or the cancer, because they do these radical resections and take everything out, and it's like the patient is hollow. I'm like, man, is this life? So that's why you have to pay attention to that. Yes, Bradley.
So these are more earlier manifestations?
Yes, if you're able to pick it up when the patient becomes diabetic, you're likely to pick it up at an early stage when just limited resection can be curative. Okay? Now, look at the normal. How does it present? It presents as bullous skin eruptions on tongue and body orifices. So you see somebody around their genitalia, around their mouth, the tongue, they have these bullous skin eruptions. And they are not on any prescription drugs, because some prescription drugs can cause this. What is the commonest drug eruptions that can give you bullous eruption? What is the name? Stephen Johnson, thank you. So, provided you know your patient is not on any prescription drugs, they have a patient that is diabetic, and when you're examining them, look at the rectum, look at the whatever area, and then the mouth, you see all this bullous skin eruption everywhere. You want to make sure you screen that patient for glucagonoma, and it's very easy. Measure serum glucagon. All right? Now,
Glucagon?
Glucagon, yes. That's why it's called glucagonoma. Now, acromegaly. You must diagnose acromegaly. Why? How do you know? Adult shoe sizes don't increase. Adult ring sizes don't increase. If your patient comes and tells you, my wedding band is not fitting anymore, and it fitted 3 years ago, there's a problem. Or the shoe size is increasing. Or you say, show me your teeth, and you could see the teeth standing on their own because the jaw is enlarging and expanding, what we call prognatism, right? Then you know this patient may in fact have acromegaly, not just diabetes. So don't assume that every diabetes is type 2. Remember that there are secondary diabetics. Keep your eyes open, examine the patient very well, okay? And then hemochromatosis, they call it bronze diabetes, right? Because the patient looks bronze-like, right? So they have multiple joint bone complaints, deep tightening of the skin, they have elevated liver enzymes, and when you do the iron profiles, you see high serum iron, high ferritin, low total iron binding capacity because they have so much iron. It's beautiful. All right, and then somatostenomas. How do you know when a patient has somatostatinoma? They have steatorrhea and they have cholelithiasis. So if I tell you a 46-year-old female patient, gravida 8, para 5, presents with right upper abdominal pain, I give you blood glucose is 350, and review of system is positive for chronic diarrhea of stool that floats. what is the most likely diagnosis of that, the most likely cause of diabetes? Now I'm painting a picture of somatostatinoma for you. Steatorrhea is fat malabsorption. And the way you know it is the patient will tell you that I have to flush my stool 3 times before it goes down. And because they are not absorbing fat and they're passing fat in stool, all of their fat soluble vitamins never get absorbed because they get leached out of the gut by the fat. Okay? Of course, Cushing syndrome, buffalo canthroplicity, dry hair, easy visibility, all that. And of course, when your patient is pregnant, the kind of pregnancy that gives you diabetes is not the one you won't see. You will see it. Okay? Excellent. So these are the ways that secondary diabetes will present. How do you then evaluate this? You measure hemoglobin A1C. Like I told you, it is high. It means the diabetes hyperglycemia has been going on for a long time. When A1C is low in somebody that has hyperglycemia, you're thinking more of glucose excess. You check the glucose, you have glucosuria, and you might have ketonuria. Basic metabolic panel, you will see low serum bicarb with high anion gap in ketoacidosis. Remember that? Now, supposing you're in a place where you really cannot measure, or you don't have time. Okay, let's say you were in a place where you really don't have access to lab. Maybe the nearest lab is like 50 miles away, and somebody is brought into you with ketoacidosis, but you have access to basic metabolic panel. You don't have access to all the other stuff. How do you tell when somebody has ketoacidosis versus lactic acidosis? A good example is, say for instance, somebody in a rural area. Yes, this is a good one. A rural area. You were the emergency room guy in this place in Wyoming. And they brought in this guy because he was found on the farm, right, out. You look at the guy, his sugar was high, and basic metabolic panel, he has low bicarb, and there is anion gap acidosis, but his blood pressure was also low. So you have somebody who is in cardiovascular collapse, who has some elevated blood sugar. And how do you tell whether the anion gap is due to lactic acidosis or ketoacidosis? There's a simple formula. Nobody's going to ask you this, but you should know it because you're being trained to be able to practice anywhere on the planet. Right? So you see, the body has no need for lactic acid. Is that true? Okay, thank you. So the body has need for lactic acid because it is lactic acid that is the byproduct of glycolytic pathway, right? So this lactic acid that goes into the cell cycle, right? So the body has need for lactic acid. Does the body have need for keto acids? Does the body do anything with keto acids?
No.
Have you seen keto acid in any normal equation in the body? No. The body has no need for keto acid, but the body has need for lactic acid. So whenever the kidneys filter lactic acid, they reabsorb it. But when the kidneys filters keto acids, it doesn't reabsorb it. So when somebody develops anion gap metabolic acidosis, and you compare the change in the gap versus the change in the bicarb, if the person has ketoacidosis, that ratio will be less than 1. If that ratio is more than 1, it's more likely to be lactic acidosis. The reason is because keto acid excretion proceeds faster than the replenishment of serum bicarb. Whereas in lactic acidosis, renal reabsorption of lactate keeps the gap wider longer. Okay, so because in lactic acidosis, the acid neutralizes bicarb, right? And it is filtered, right? So the bicarb goes down, gap increases. But remember, it is the lactic acidosis that is widening the gap. And because it keeps getting reabsorbed, the gap stays longer, even though the bicarb is regenerated, right? So the bicarb is regenerated faster than the gap closes because lactic acid gets reabsorbed. So that ratio usually will be greater than 1. But in ketoacidosis, because it is easier to filter the keto acids than to regenerate the bicarb, the gap will be less than 1. Okay? Nobody will ever ask you that. You guys are like stock of pediatrics right now. They're looking at me like, all right, so this will wake you up. Get up. So,
That's what I was looking at too.
what do you think? This is a 28-year-old female with a history of type 1 diabetes. Was brought to the emergency room after she was discovered by her boyfriend unconscious in the bathtub with a slash wrist. Vital signs: she was hypotensive, tachycardic, she was in shock. Blood gas, there you are, and this is chemistry. So what do you think is going on here?
CO2, are we doing what we did last?
You're doing everything. You are evaluating this patient from head to toe.
Okay, so her CO2 is low, her bicarb is low as well, and her pH is low. So it's a metabolic acidosis.
Good. So it looks like this person has metabolic acidosis with
With the secondary respiratory
acidosis. Good. So what do you want to do now?
Then I have to do my formula to metabolic acid, which we said.
Yeah.
So acidosis 8, so 1.5 times the bicarb plus 8 plus or minus 1.5.
So 1.5 times
Plus or
7.
minus 2.
I know. 1.5 times 14 is 13 plus 6.5, right?
1925.
Okay, so that's 19.5 plus 8. That is 27.
CO2 is
7.5. So she's fine. So she doesn't have any meat disorder. She just looks like a simple metabolic acidosis.
Okay.
Right, so what next are you going to do?
Do I have to do the anion gap?
So which is
So
128 plus
3.6.
so we just say
90 plus 13.
132 minus 113, right? 9? 119. So anion gap is 19.
Okay, so I have to subtract
So that delta gap.
7.
So and the delta gap of 7. What is the initial bicarb now?
20.
20. So this person has a problem, right? So the initial bicarb is 20. So she has both anion gap metabolic acidosis and normal gap metabolic acidosis. Now, anion gap metabolic acidosis could be due to diabetic ketoacidosis, or it could be due to lactic acidosis. Which one do you think it is?
Wait, you said it could be due to what?
Anion gap metabolic acidosis could be due to lactic acidosis because she's in shock, or it could be due to ketoacidosis because she's type 1 diabetic. And she was found unconscious, so she must not have been taken into it.
Yeah.
No. Oh, okay. So can anybody tell me how would we find out whether this is lactic acidosis or exactly? That's what I'm asking you, right? So by how much has the gap changed? By 7, right?
Yeah.
By how much has the bicarb changed? Am I 24, right?
11.
By 11. Is this greater or less than 1? It's less than 1, right? Good. So what is it? Is it? Exactly. So she's more, her problem is more of ketoacidosis than lactic acidosis. Okay? Why is that? Is that important?
More keto than lactic, is it?
It's more, it's less than 1. Keto, more keto than lactic. Right? Changing the gap by changing serum bicarb. Right. Why is it important to what?
We're just trying to figure out what the increase is. Delta gap over change.
It's here. Changing anion gap divided by changing serum bicarb.
Okay. Oh.
talking about that.
Maybe coffee.
All right, you got it now?
Yeah.
Okay. So, why is it important? Is it important to kind of figure it out?
Yeah.
Why?
Management is different.
Yes, because you know that when you have enough acidosis, your catecholamines, they lose efficacy. So you can actually become hypotensive from severe acidosis. In this patient, you want to figure out, does the patient need fluid or does the patient need insulin? Because if you rush fluid into the patient and the patient doesn't need fluid, you put them into volume overload, pulmonary edema, and you complicate their situation. Okay? Good. Let's talk about how do you manage hyperosmolar hyperglycemia. It looks complicated and difficult. Just don't try to understand it. Just listen to it. Whenever you have hyperosmolar hyperglycemia, you need three things: IV fluids, insulin, and potassium. That's it. If that is all you remember, you're done with this one. Because the rest of it is how you give the fluid, how you give the insulin, and how and when you give the potassium. That is what the rest of it is. So, IV fluids, you determine if your patient is hypovolemic, hypotensive, or in cardiogenic shock. If they're in cardiogenic shock, you give them 0.9 sodium chloride, 1 liter per hour. Or you might even use volume expanders. That's how you give them, IV fluids. If your patient is in cardiogenic shock, you need to put them in the ICU and monitor their parameters, hemodynamic parameters, the pulmonary waves and all that, right? If they're only mildly hypotensive, you evaluate for the corrected serum sodium. Whenever serum sodium is above 100, whenever blood glucose is above 100, serum sodium drops. So many times in somebody with hyperglycemia, you must correct serum sodium for serum glucose. How do you do that? You add 1.6 for every 100 milligram above 100 milligram per deciliter. So if somebody's serum sodium is say 130 and the blood glucose is say 200, their corrected serum sodium will be 131.6, right? So you add 1.6 milliequivalent to the serum sodium for every 100 milligram above 100 milliequivalent per deciliter. If you're familiar with arithmetic, basically what I'm telling you to do is to take the serum sodium and add it to 1.6 times serum glucose over 100. That is the mathematical way of saying add 1.6 to the serum sodium for every 100 milligram above 100 milligram per deciliter. Okay? So if the serum sodium is say serum glucose is 500, right? And serum sodium is 128. You have to add 4 times 1.6 to 128. Okay? You got it?
Mm-hmm.
Okay. So you evaluate first corrected serum sodium. If your corrected serum sodium is high, you shouldn't use normal saline. You should use half normal saline. Okay? If your corrected serum sodium is low, you should use normal saline. If it is normal, you should use half normal saline. When the glucose gets to 300 milligrams per deciliter, you change to D5W from normal saline. So you see, everything under here is not something you should worry about. You will learn this in the field. When you get in the ICU and you see DKA, or you go to the emergency room, you see DKA being managed, this is exactly what you will see. So don't try to memorize this. This is just for you to know how we manage it. All you need to know is that when you have hyperosmolar hyperglycemia, IV fluids, insulin, and potassium. Now, potassium is important because if serum potassium is less than 3.3, do not give insulin until you have given potassium. You know why? Right? Yeah. Because if you give insulin to somebody that has hyperglycemia, when the potassium is 3.3, you will drop that potassium to like 1.8, and your patient will go into some fibrillation, and there is no guarantee whether it will be atrial or ventricular. You know what the difference is between atrial fibrillation and ventricular fibrillation. Ventricular fibrillation is pulseless, okay? So that's a full code right there. And you would have brought that on. So don't give anybody with hyperglycemia insulin unless you know absolutely what the potassium is. Because hyperglycemia will not affect their heart. Your insulin will drop their potassium low and you will kill them. Alright, so that's what this is about. And insulin, how do you give it? 0.1 unit per kg as a bolus, and then you continue with infusion. And you monitor the glucose. So this is just clinical details. This is not what you learn in classroom. You learn it by the bedside. Okay? So don't know what is important in that figure right there. Okay? Moving on. So the same thing, when there is ketoacidosis, what is the difference? The difference in management when there is ketoacidosis is that you assess for bicarb. Everything else is exactly the same. IV fluid, insulin, again potassium, but this time you check for bicarb, and you have to decide, do you need to push bicarb? And how do you determine that? You look at the blood gas, look at the bicarb. If the pH is less than 6.9, of course you should push bicarb, because if you don't, your patient will become hypotensive. Remember I told you, catecholamines lose efficiency when there is severe acidosis. The blood vessels don't respond to them anymore. So they don't cause vasoconstriction like they should. So your patient's blood pressure will drop. Okay? If pH is above 7, you don't need to push bicarb. So that's all. Everything else that is here is exactly what I told you earlier. Alright? Again, be careful with insulin unless you know what the potassium is. Somebody with high serum glucose. Okay? Now, there is something strange that happens when you're managing ketoacidosis. When you're managing ketoacidosis, it is very expensive to measure serum ketones, right? So we normally use urine ketones to monitor the treatment. Well, it turns out that we found out that when we're in the beginning stages of managing ketoacidosis, instead of the ketoacidosis to get better, it actually gets worse. And we used to think that, and many clinicians in those days used to think that maybe we need to give a lot more insulin. And then when they give a lot more insulin, they realize they drive the patient into hypoglycemia and the ketone didn't get better. We now went back to the classroom to figure out how exactly is this happening. It turns out that when the liver forms ketone bodies, it begins with acyl-CoA, right? And it ends up with acetoacetate. Acetoacetate does not need any enzyme. If you put acetoacetate right on this table, it will release its own carbon dioxide and form acetone, and you begin to smell acetone in the air. But you need beta-hydroxybutyric acid, butyrates, to convert acetoacetate to beta-hydroxybutyric acid. Acetone, acetoacetate, and beta-hydroxybutyric acid are the primary ketone bodies. Okay? Once you begin to treat the patient, see what happens. The beta hydroxybutyric acid begins to get converted into acetyl-CoA and gets thrown into the TCA cycle. Do you understand what I'm saying? So this is ketoacidosis developing. This is what begins to happen when you begin to treat the patient. Now the question is, so why does the patient show more ketone bodies in urine with treatment? Because beta hydroxybutyric acid is the primary ketone body in DKA. The blood and urine test measure only acetone and acetoacetate. So when you begin to treat the patient, the acetone and acetoacetate concentration increase because of the conversion of beta hydroxybutyric acid to acetyl-CoA. And that gives you that increase exaggerated urine response to ketone bodies. Okay? So if you can understand this, fine. If you can't, just know that when you start treating ketoacidosis, your urine will show increasing ketone bodies before it gets better. And that is because of this reaction. Again, this is another clinical detail. I don't think you need to know it. This is not something you learn in classroom. This is something you're supposed to learn in the clinic. But I just want to fulfill the books. So when you're managing ketoacidosis, you're monitoring glucose, you're monitoring bicarb. When your blood glucose drops now to 250 to less than 250, and your serum bicarb is still under 15, you will begin to slow down on your insulin because your patient is coming close to normal, right? Once your bicarb is above 15, they're coming close to normal. You stop insulin infusion, you stop IV fluid, you begin to give them subcutaneous insulin. Once you stop giving insulin drip, you're ready now to put your patient on a long-term insulin, right? And long-term insulin is two forms, right? You have what is called split mixed regimen or basal bolus regimen. Split mix is a mix of long-acting and short-acting insulin. Usually, you use regular insulin and NPH insulin, right? So you can have 70-30. So usually it will be 70% long-acting, 30% short-acting. So it's called split mixed. Or it could be 50-50, NPH insulin or regular insulin. And it is usually injected twice a day, before breakfast and before dinner. The logic is that short-acting insulin lasts for under an hour or two, right? But the long-acting insulin, like the NPH, will last for up to 6 to 8 hours. So the logic is, once you give somebody 70-30, usually 70 NPH and 30 regular, pre-mixed, and they inject it just about 30 minutes before they eat, the short-acting insulin will take care of the glucose load that is going to come from the food. And then the long-acting will keep the sugar low until they eat again. Right? So that's the logic of it. All right? So that was what we used to do. But now, we have this insulin that I like, super long, like Lantus insulin. Right? So, the second regimen that is now relatively new is called the basal bolus. So you take Lantus that lasts for 24 hours. The patient takes the Lantus either in the night or in the morning, usually in the night, right? It's going to last for 24 hours. So that is called the basal insulin level because that is the way your body secretes insulin. It releases insulin at a constant rate. Then once you eat, the beta cells increase more insulin because you're eating. Once you fast, insulin goes back down. So basal bolus gives long-acting insulin once to provide the basal insulin dosage, and then patient is now given regular short-acting insulin about 10 to 15 minutes before they eat. Okay, so it's called basal bolus. The regular that you take with every meal is the bolus. The long acting you take once a day is the basal. So those are the two ways you give insulin: split, mixed, or basal bolus. Okay? Yeah. It's 9:50. I'll give you a break in 10 minutes. You want a break now? Yeah. Okay, go.
So the basal is the long acting that you take at night, and the bolus is the one you take right before you eat.
Yes, exactly. It is usually the regular one, very short acting like Lispro or Aspac. All right, so in the last hour, thank you. Oh, thanks. All right, so there is something that you need to be aware of. This is very important. What is all this doing?
Los, man. Los is cracking jokes.
All right, so this is what I'm going to talk about is very important, so pay attention.
Okay.
Many times you will see patients that will come to you with, they are on insulin, and they will come to you and they will tell you that their blood glucose is high every morning. High blood glucose in the morning is not always because the patient needs more insulin. Sometimes it could be because they need less insulin. Because there are two reasons why your blood glucose could be high in the morning. One of them is known as Down's phenomenon. You see, Down's phenomenon is a reflection of the circadian rhythm. If you notice, if you live near ambulance, when do you hear the sound of ambulance the most?
But it's coming to you. Like it's when it comes.
Exactly. But around what time of the day do you hear it?
7. It's like morning time.
Between 4 and 7. That is because everything shuts down when you're sleeping. Then when you're waking up, that is when your circadian rhythm, your glucose, your cortisol, everything else begins to come up with you. Most heart attacks happen between 4 and 7. Okay? Now, so what happens is, when the patient is waking up, right, they have a surge of growth hormone because of circadian rhythm. And of course, you know what growth hormone will do? It will increase their blood glucose, right? Their blood glucose will increase. The kidneys will filter it. They may wake up to go pee because of the glycosuria. And then, before they eat, they check their blood sugar. And you see that their blood sugar level will be high. It is high because it is just early morning and they don't have enough insulin from the night before. All right? That is called Down's phenomenon. It's because of the rise in the counter-regulatory hormone creating a relative deficiency of insulin. Right? It's called Down's phenomenon. But it could also be due to what is called Somogi effect. Somogi effect, on the other hand, is when a patient took too much dose of insulin at night. Mm-hmm. And when they are now sleeping, their long-acting insulin will drive their glucose so low, they will become hypoglycemic in their sleep. They may have a nightmare. And because of that hypoglycemia, they will trigger the counter-regulatory response, growth hormone and cortisol excess. And that will create elevated blood sugar when they wake up. Now, you could see that Down's phenomenon is due to insulin deficiency. Somogi effect is due to insulin excess. They both present with elevated blood glucose in the morning. Let me say it again. Down's phenomenon is due to relative insulin deficiency, whereas Somogi effect is due to insulin excess. They both present with elevated blood sugar in the morning. How do you tell them apart? Because one person needs less insulin, the other needs more insulin. If you give the wrong person the wrong insulin, you will kill the patient. The best way to tell it apart is to check the sugar at 3 a.m. Usually, in patients with Somogi effect, the 3 a.m. sugar, you will tell the patient, wake up at 3 a.m. and test the sugar. Right? If the sugar is low at 3 a.m., that is Somogi effect. You need to reduce your nighttime insulin. Whereas if the sugar is high at 3 a.m., that is Down's phenomenon. The other thing you can ask is somebody tells you, my sugar is always high in the morning. You said, you get up in the night to pee. You say, yes, I get up like 6 times in the night. You're likely dealing with Down's phenomenon. Or somebody tells you, oh, my sugar is always high in the morning. Then you ask them, do you get up to pee? No, I sleep all through the night. I have a lot of bad dreams. You're probably dealing with Somogi effect. You understand that? Mm-hmm. This is commonly tested and you should know it. Okay? So Somogi effect is an indication for decrease in evening dose of the insulin, and Dawn is an indication for increasing the dose of the evening dose of the. Huh? The green one. Yeah. You want the low blood sugar. We've gotten all sophisticated now with our insulin pumps. You wear them like that, like a beaker. And the needle is buried in the subcutaneous tissue. And it delivers insulin at a constant rate. Right? They are usually computerized and they deliver fast-acting insulin, not long-acting, fast-acting, short-acting insulin. Okay? They deliver it at a steady rate, known as basal insulin infusion. And the patient can give themselves boluses as they eat. Okay? Taking the insulin secretory blocker. It has all these advantages. Single needle placement, you don't have to keep poking yourself. It's very convenient. It gives better blood sugar control. Patient can live their life. There is no risk of hyperglycemia. But see, it costs about $5,000. Very complicated device. You can't swim with this. High risk of infection. And if for any reason the needle will get dislodged and you lose insulin delivery, the patient will go into DKA in less than 2 hours. Okay, so it's good, but also dangerous. Now, they actually have insulin pumps that are attached to a glucose sensor, so that the pump is now controlled by the number from the glucose sensor. So the glucose sensor senses the glucose. When the glucose is normal, the pump holds. When the glucose is high, the pump is triggered to give insulin. And that combination of insulin pump and glucose sensoring system is what is known as artificial pancreas. Okay? Because the ultimate is transplantation. And usually patients that have insulin-dependent diabetes mellitus with end-stage renal disease or brittle diabetes with hypoglycemia unawareness. What is that? A brittle diabetic is somebody whose blood sugar fluctuates at extreme levels for no reason. They're on the same dose of insulin, but the sugar will be fluctuating. It will go from very high to very low. That is called brittle diabetics. And especially when brittle diabetics have hypoglycemia unawareness, that means they have lost their sympathetic early warning signs. So they usually do not know when their blood sugar is dropping until they pass out. That is the second indication for transplantation. How do you do it? There are so many types. You can transplant pancreas and kidney together for IDEM with ESRD, you can do the pancreas after the kidney, and you can do the pancreas by itself. And now there is a procedure they use to harvest the beta cells and transplant them. But it's so elaborate because look, a 70 kg man will need about 1 million islet cells. And you cannot find 1 million islet cells in one person. So you have to harvest it from multiple people, and then the risk of rejection and all those things now come in. So these are all sophisticated ways of treating diabetes now. I hope you never get to deal with all that, because I'm hoping that you will control diabetes at this level using no insulin. There are non-insulin hypoglycemic medications. They belong in 5 categories. 4 distinct categories and 1 overlap. You have the insulin secretagogues. They stimulate the release of insulin from the beta cells. You have the insulin sensitizers. They don't stimulate insulin release. No, they sensitize the peripheral tissue to the available insulin. Then you have the glucose blockers. And then you have the glucagon suppressors. Those are the 4 main categories. Then the 5th category are called the incretins mimetics. They suppress glucagon and they boost insulin. They do what these two do. Okay? So let's talk about insulin secretagogue. I want you to pay attention. Medications that stimulate insulin secretions are sulfonylureas. You have 1st generation and 2nd generation, and you have the meglitinides. They do exactly the same thing. It will make no sense for you to put a patient on the sulfonylurea and meglitinides. What is that? They are both stimulating beta cells. Then you have the insulin sensitizers. You have the biguanides and you have the thiazolidinediones. Unlike insulin secretagogue, you can actually combine biguanides and thiazolidinediones. They are like the calcium channel blockers. Remember the calcium channel blockers? You have the non-dihydropyridines and dihydropyridines. You can combine them because they work in so different ways. So you can actually combine. These are the only 2 that belong to the same class that you can combine. Biguanides, because they walk through the hepatic AMK pathway, and the thiazolidinediones, they walk through the peripheral PPAR gamma pathway. You can combine them. Now, the glucose blockers, there are those that block the glucose in the kidneys and those that block the glucose in the gut. The point is to get rid of glucose. Okay? The ones that block it in the gut are called the alpha glucosidase inhibitors. And the ones that block it in the kidneys are the serum glucose SGLT2 inhibitors. They block it in the renal tubules. Okay? Serum glucose transporter 2. And they have the glucagon suppressors, the amylin analogs. They mimic the beta cell amylin. Beta cell amylin is a hormone that suppresses glucagon, delays gastric emptying, and promotes satiety. So this actually controls people's appetite. These glucagon suppressors, they are very expensive. Okay, so most of the time in practice, you find yourself using glucose blockers, insulin secretagogues, and insulin sensitizers. Then there are incretins mimetics that suppress glucagon and boost insulin. Let's take them a little bit more details. So incretins, what are they really? Incretins are actually intestinal glucagon-like peptides and gastric inhibitory peptides. So those 2, GLP and GIP, together they are known as incretins. Anytime you eat, you stimulate the release of these incretins. You know what is interesting about them? They are released. You know what the half-life is? 2 minutes. Before you finish eating, there is no sign that they were ever secreted. What do? They stimulate insulin release and they inhibit glucagon release. Okay? The idea is to lower blood glucose. But because they have such a short half-life, they were difficult to produce. So what we now did was we know that incretins the reason they have such a short half-life is because they are inactivated by DPP4. Okay, DPP4 is the name of the enzyme that inhibits and inactivates incretins. So we said, okay, fine, we can prolong the half-life of incretins by blocking DPP4. So that now you have DPP4 inhibitors. So the gluten, the Janivia, Omlivia, Regenta, Messina, all of these are DPP4s. They are available for treating diabetes. And then there are these injections that are incretins. Because they are injected, they are no longer subjected to DPP4 enzymes and they can last. Your Byetta, Victoza, okay? So that is the group called incretin mimetics. They consist of the injectables and the DPP4s inhibitors, okay? This is your serum glucose gold transporter 2 inhibitors. They block glucose reuptake in the proximal convoluted tubule. That's your Invokana, your Faxiga, and your Jadians. Okay? They all end with fluoxins, right? Fluoxins, fluoxin, and fluoxin. Okay? They block the SGLT2. The reason we have to specify 2 is because 2 is the one that is responsible for 90% of the glucose reabsorption. It is 2 that you find in the proximal convoluted tubule. More in the thick segment of the descending loop of Henle is SGLT1 that accounts only for about 10%. So this is the one that this Invokana, Faxiga, that's what they block. The problem with this is that they block glucose reabsorption, so they cause glycosuria. And because they cause glycosuria, they predispose the patient to urinary tract infection. Okay? That's why they're not, people don't like them too much. These are your alpha glucosidase inhibitors. You know, when you eat glucose, complex carbohydrate, it is broken down by your amylase and all the other enzymes, and it's broken down into dipeptides or disaccharides. Those disaccharides are broken down at the brush border, intestinal brush border, into the glucose that is actually absorbed. The enzyme at the brush border that breaks down those disaccharides, your maltose, your sucrose, and your oligosaccharides into glucose that is actually absorbed are these alpha glucosidase. So these are the enzymes that acapose, miglitol, and forglipose blocks to inhibit glucose absorption. Okay? The bad thing about them is that because they block glucose absorption, they leave glucose in the colon, and glucose attracts water to itself. Patients get diarrhea. Because again, that is one of the reasons people don't like them very much. Especially when you combine them with metformin. Metformin already causes diarrhea. You now give somebody metformin and macabose. Oh, you're going to really keep them in the bathroom. And then the insulin sensitizers we talked about. I gave you the 2 pathways. The adenosine monophosphate pathway and the PPAR gamma. I just gave you what they do and which medications are used. The only insulin sensitizer that works through the AMPK pathway is glucophage, metformin. The insulin sensitizers that work through PPAR gamma pathway are the thiazolidinediones, Actos and Avandia, pioglitazone and rosiglitazone. Okay?
You said not to use one or the other. Okay. For
these are the only ones you can combine that belong to the same group. You can combine the insulin sensitizers because they work through different pathways. And they're the only ones you can do that. Again, these are your insulin secretagogue, the two groups, sulfonylureas and meglitinides. Sulfonylureas are divided into two groups. First generation that are no longer in use in America, but you find them in use in many, many developing countries. And they have the second generations like glibenclamide, glipizide, and glimepiride. The one that is used most here is glyburide and glipizide. And this is how it works. The sulfonylurea, they bind to the receptors on the beta cells, they close the potassium channels and open the calcium channels and stimulate insulin release. That's how they work. The meglitinides are your repaglinide and natglinide. Good. Now, here is a table of every single non-insulin hypoglycemic agent I've talked about with a summary of their side effects, the dosage, and how effective they are in lowering hemoglobin A1C. That's for reference. Again, it is extremely important for you to know how to combine oral hypoglycemic agents, right? You can combine metformin with sulfonylureas. That's very good. You stimulate the synthesis and you sensitize the tissue. Effective. You can combine metformin with repaglinide and with meglitinides. Yeah, because again, you stimulate the release and you sensitize the tissue. You can combine metformin with pioglitazone. Yeah, again, you sensitize and you stimulate, right? You can combine meglitinides with TZDs, the thiazolidinediones, because meglitinides, they will stimulate insulin release, and the rosiglitazone and the pioglitazone, they sensitize the tissues to the insulin. So you can combine Precoz or Miglitol with sulfonylurea, stimulate insulin release and get rid of the glucose in the gut, right? You can combine a number of things. So when you have somebody on metformin and sulfonylurea, say they are on metformin and glipizide and they are not controlled, you can add rosiglitazone to that, right? For the first time in history, we actually have more medications to control blood pressure than we have to control blood sugar. So it becomes extremely important for you to know what you can combine and what you cannot combine. Very important. Pay attention to this table. I know you're all busy, you all look tired, and you probably won't remember this, but hopefully when you're reviewing it, you will review it because I will test this heavily. Okay? Now, insulin, I've been talking about insulin, long-acting, short-acting. These are all the insulin there are, and this is the duration. You can see the longest acting ones are the glargines, the detamir, and the short-acting ones are aspart, lispro, glulicine, and regular insulin. They all last less than 8 hours, and your NPH, 12 to 16 hours. Okay? One thing I want you to know here, I already told you about this, how you do the split dose or the basal bolus. We talked about that already. You never mix long-acting insulin with short-acting insulin. In other words, never tell your patient to draw Lantus and then draw regular with the same syringe and inject at the same time. No, you inject them differently. Very important. Sometimes patients, and by the way, you know that insulin is, the vials come as U100. U100 means that the patient has in every meal 100 units. Okay, that's what it means, U100. There's 100 units of insulin every meal. Okay? So you have this 1 meal syringe, and the patients can have the 60 units, which will be 0.6 mils, and the syringes are very, very thin, right? So they can draw that and see it. problem is sometimes patients have bigger problem from diabetes and they can't see the gradation of the syringes very well. So when you prescribe, you have to be careful that the patient asks for insulin syringes that they can read. Otherwise, they run the risk of overdosing themselves on insulin because they can't see the numbers on the syringe. And then there are times patients are on very high dose insulin, like the patient, you have some patients that are on like, most of my patients are on maybe 60 units in the morning, 40 units at night. But I have patients that are on 100 units in the morning and maybe 100 units at night. I have one patient that is actually taking this. And every time she goes into the hospital, she tells them that's what I take. And they'll say, no, that is too much insulin. They try to give her something low, she get really sick, and then they get it. And then they give her what she needs. There are patients that need such a high dose of insulin that one vial of the U100 cannot give them the single dose they need. So you have to now change the insulin formulation. And the higher formulation that you give them is the U500. Okay, that U500 is the special dose insulin that has 500 units of insulin in every meal of insulin. And nobody will prescribe it easily. Before you can get it, you have to talk to the pharmacy. Pharmacists don't dispense it easily. And to make it clear, they dispense it with special needle with a green hub. So you just need to know that it's there. You may never need it, but if you need it, at least you know it's there. Okay? So when the daily basal bolus insulin requirement is more than 200 units, you're better off with U100 insulin. Diabetes, you have to manage. If you don't manage, you have some serious complications. And you can see them here: diabetic foot, peripheral vascular disease, stroke, heart attacks, cataracts, glaucoma. What is glucose control? Glucose control is when your random glucose is always less than 200 and your fasting is always less than 120. Okay, and your A1C average is 7. That is when you're controlled. If you're not controlled, you have a problem. Now, there is a lot of confusion about the use of aspirin in practice among diabetics. This is the American Diabetic Association. It's a joint statement of the American Diabetic Association and American Heart Association. And here's what they say, right? They recommend aspirin therapy for primary prevention of heart disease for persons with diabetes over the age of 40 who have additional risk or who have additional risk for cardiovascular disease and no contraindication to aspirin. American Stroke Association further recommend aspirin for cardiovascular prophylaxis among persons whose risk is sufficiently high for the benefit to outweigh the risk associated with treatment. For primary prevention of stroke, they recommend aspirin in men and state that aspirin can be useful for primary prevention of stroke in women whose risk is sufficiently. These stupid things that they just write. Basically, to give aspirin to anyone with more than 2 cardiovascular risk factors and over the age of 40. Okay? These are all, they practice languages like this because of litigations and liabilities.
So they don't recommend it to men?
For women. It's not expected in women, that's the reason. And this is a table to help you see the relationship between hemoglobin A1C and mean blood glucose. So when somebody has hemoglobin A1C of 14, that means their glucose is averaging 380. When somebody has hemoglobin A1C of 7, that means their blood glucose is averaging 150. Okay? This is a milligram, this is millimoles. We use milligram in the US. They use millimoles in England. So pay attention to the middle column. Alright? So you could see that A1C actually tracks very well blood glucose level. Okay? And you really want, when A1C is above 7, then your patient is cruising for cruising because the complications get worse the higher above 7 A1C is. Okay? Now, the question will be asked, time and again. So, what is the ABC of glucose control? You want to manage A1C, that is the A of ABC. You want to control blood pressure, make sure blood pressure is controlled. And the question is always asked, which one has more advantage in a diabetic hypertensive patient? Is it blood pressure control or blood sugar control?
Blood pressure.
Blood pressure, yeah. Blood pressure, you get more than your blood with blood pressure control, okay? That does not mean you ignore blood sugar control. It just means that you should pay more attention to it. And again, this is the cholesterol treatment, ABC. So ABC of diabetes control is monitor A1C, control blood pressure, increase cholesterol. Again, this is a table that tells you how to treat high blood cholesterol in somebody with diabetes. You have to calculate their atherosclerotic coronary vascular disease risk. And the magic number is 7.5. That is what determines everything along with age. And you can choose to use high intensity, moderate intensity, or low intensity statins. And I've listed them on the side there for you to know. What are some of the complications you're worried about in diabetics? Diabetic retinopathy. That is why we screen annually. We do retinal scans, and now there are cameras all over the place that will identify this. And treatment is very easy. It's photocoagulation by laser. So it's good to kind of identify it, because if you don't, diabetes is the second leading cause of blindness in adults, second only to glaucoma. So it's extremely important that you screen annually for this. And then, just remember that the reason they go blind is because with so much glucose in circulation, the blood vessels, new blood vessels begin to form. This formation of new blood vessels is what is called neovascularization. Because those blood vessels are being formed under abnormal circumstances, they tend to be weaker than normal blood vessels. So with elevated blood pressure, they can actually burst. And when they burst, they bleed behind the retina, and they can cause retinal separation, detachment, and blindness. Okay, so neovascularization is very important, causes vitreous hemorrhage and the blindness. So what laser beam does, laser photocoagulation, what it does is to burn off those new blood vessels before they could rupture or bleed. Okay? Diabetic nephropathy. You need to know about Wilson lesion, because that is usually what you see when you do kidney biopsy. You see Wilson. You see all the sclerosis of the glomerulus. It is called Wilson syndrome. Okay? Lesion, not syndrome, lesion. Okay? And how do we treat this? You treat it with ACE. How do you know when you treat it, your patient will have microalbuminuria? They will leak albumin in urine. You are not supposed to find albumin in urine. If you find albumin in urine, something is wrong. In a diabetic patient, most likely diabetic nephropathy. Okay? And when you do the biopsy, they stage it like this. But what is more important is for you to remember that anywhere from 30 to 300 is microalbuminuria. When it's more than 300, it's macroalbuminuria. Okay? Peripheral neuropathy, of course, with increasing blood glucose, you get atherosclerosis, you begin to affect the vasa nervorum, the blood vessels that supply the nerves. They start getting clogged and the nerves die. And when those nerves die, the patient has neuropathy. When the nerves are dying, they get burning. And when the nerve is dead, they lose sensation altogether. Okay, so you get paresthesia and then you get anesthesia. All right? And sometimes the nerves just become permanently painful. Yes?
Can you go back to the last slide real quick? Just, I just want to clarify, because you said greater than 300 is microalbuminuria?
Macro.
Greater than
this is how nephrologists stage kidney disease. Clinically, 330 to 300 is micro, more than 300 is macro. Okay? Yeah. And then, how do you manage that neuropathic pain? Gabapentin. That is what we use, but some folks say that tricyclic antidepressants, some antidepressants may work. They all modulate sodium transport across nerves, so they may work, but reality, what most people use in practice is gabapentin or pregabalin. Pregabalin is very expensive. These days, with the opioid crisis in the country, nobody is using opioids anymore for treating neuropathic pain. We're being forced to use Neurontin and Lyrica. And there are devices to actually monitor opioid use now. And people have been in trouble for using opioid inappropriately. When you lose sensation, then you're not able to recognize when you have a wound. And when you don't recognize the wound, you won't respond to the wound. You won't treat it like you should. Then it festers. And when it festers, it threatens the foot. Think about it. If you have vascular disorder, right, and you have nerve disorder, so you have a wound, the wound is not going to heal because you don't even feel pain. And you don't have good blood flow to the wound, so healing is prolonged. And because you're not sensing pain, you won't pay attention to the wound. That is why it's very easy for diabetics to develop little wounds that will spread very quickly, especially with uncontrolled blood glucose everywhere. The bugs are feasting and patients lose their feet very quickly. So one of the things we do also is to do annual foot exam for diabetics. So you have to take them out and take off their shoes, the socks, and you look in the web spaces, in those areas, pressure points, because that is where the wounds are most of the time. And most of the time they come from little gravel in the shoes that they may not know. And with continuous grinding and walking, the gravel will find its way through the skin, create a puncture wound, and then the infection starts. Okay? And it spreads very quickly. Many diabetic patients don't understand. When you tell them you need to increase the intake of fruits and vegetables, what most people hear is the fruit. They don't hear the vegetables. And the truth is that as far as diabetes is concerned, there is no difference whether you eat banana or you drink Coke. It does not matter. Look, a can of Coke is about 100 calories. One big banana is about 120 calories. So that is why diabetic patients, you need to warn them. I used to tell my patients, I need you to increase the intake of fruits and vegetables. And I was hoping that they will eat vegetables with the fruit. Because if you eat vegetable with the fruit, the vegetable will modify the glucose absorption from the fruit. But if you ignore the vegetable and you eat just the fruit, of course the sugar will get worse. Right? So many times I tell my patients, I need you to increase the intake of fruits and vegetables. They say, okay. Then they come back and see me 3 months later, and A1C is like 16 from 10, and blood glucose is high. I'm like, what happened? You didn't eat the fruits and vegetables? Say, oh, no, I eat fruits and vegetables. Okay, when was the last time? Just last night I had a bowl of grapes. I'm like, what else? And banana. And what else? An apple. Like, where is the vegetable? Oh. And there's a reason people do that. Fruits are natural fast food. You don't need to prepare them. Vegetables, you have to look for a way to make them tasty. People don't have time, or the skills, or even the knowledge to do that. So they end up eating a lot of fruits. Warn your patients. All right. So, I think I'm done. I have a number of questions. We have 20 minutes. So, 38-year-old female diabetic unwilling to take insulin presents with hemoglobin A1C of 13% on maximum doses of metformin, glipizide, and pioglitazone. What changes will you make to help this patient control their blood sugar? would you add acarbose to this? Benny, would you add acarbose to it? Yes or no? And why?
No,
No, because acarbose will give her diarrhea. And she's already on metformin, so that is not a good idea. How about, of course, if you won't give acarbose, you won't give glycet, right? Right? There's a, yeah, we shouldn't do this question because you guys didn't pay enough attention during the class. Do you have any question based on my lecture? After your pediatric class or test, I will have you back. Now I feel like you guys are like on loan to pediatrics. All right.
We'll be all yours next week.
We'll be back. Oh, that makes sense.
Justin, should I remove the
Go do your makeup? Like eyelash? Oh, for the central? I know, bro. Hey, those freak out, bro. Was it me? Was it? Hey, where you going, dude? Hey, for the first time. Ready? What did I do? You make everybody laugh. I like to read it though. You never read it. You never read it, Lois. My message is.
I was like, oh God.
Library to library.
It was the first time I actually wanted to go to the library.
I just heard the reaction. That was nice too. It was like a little coffee shop. Everyone was like,
Oh, thanks.
like, nobody moved. You got back up. I was like,
Hi. What's happening? I'm alive.
well, I saw you like went down, and I was like, that's how you got